Once again, good morning and welcome to the inaugural session of the Patient Safety Webinar Series. Thank you everyone for joining us. Before I introduce our speaker, I would like to share a little bit about this webinar series, as this is the first session of the series. The Patient Safety Webinar Series is co-sponsored by the NNLM South Central Region and by the University of North Texas Health Science Center Institute for Patient Safety. The series will feature expert guest speakers presenting on topics related to the fields of patient safety and healthcare quality. Throughout the series, we hope to empower healthcare professionals, patients, and health information professionals to support the elimination of preventable harm and achieve the highest quality in healthcare possible. The NNLM SCR, as an outreach arm of the National Library of Medicine, is proud to be working with our partner, UNT HSC Institute for Patient Safety, on this collaborative project. Now it's my pleasure to introduce our first guest speaker for this series, Katherine Pohlman, or Katie. Dr. Katherine Pohlman is the clinical research scientist at Parker University, specializing in research methodology, patient safety, and chiropractic care for pediatric, pregnancy, and postpartum populations. She has been active in scientific publishing since 2009, performs peer review for several journals and conferences, and serves on the editorial board for 2 chiropractic journals. Dr. Pohlman is a co-investigator for several national and international clinical investigations, including the SafetyNET projects, which I believe she will be talking about later today. Her passion for rigorous methodology and innovative study designs has been recognized through her PhD program at the University of Alberta, with awards including the Distinguished New Investigator Travel Scholarship to the Integrative Medicine and Health Conference, Graduate Studentship Grant through the Women and Children's Health Research Institute, and an educational fellowship through NCMIC Foundation. In addition, she is an associate fellow for the University of North Texas Health Science Center Institute for Patient Safety, as well as an inaugural fellow of the Chiropractic Academy for Research and Leadership program. I'm going to go ahead and switch over to her slides, and I will now pass the ball over to Katie. Katie, good morning.
Good morning, Sarah, or good afternoon, depending on where we are at. Thank you for that introduction. And yep, I will be speaking on SafetyNET a lot today, as well as understanding patient safety. But I'll start out just with a thank you for hosting, for this opportunity and this partnership. So the outline for today, I'm just going to talk briefly on what patient safety is and some of its complexities, the current state for spinal manipulation therapy, patient safety research, as well as going into what SafetyNET is doing ongoing, as well as future opportunities. So the definition of patient safety comes from, that I'm using, comes from the Agency for Healthcare Research and Quality. It's the avoidance of injury or illness resulting from receiving healthcare. Primo non nocere, hopefully I pronounced that correctly. First, do no harm. It's the guiding principle for physicians and healthcare providers. That the patient's well-being is our primary consideration. And it's a simple enough definition, but a book that I like to use is called Safety Culture by Pantankara, and he's building and sustaining a culture of change in aviation and in healthcare. So aviation has done a wonderful job of putting in what they call highly reliable organizations and using those models into healthcare. And one of those models is at the very, patient safety is at the very tip of this, the avoidance of injury or illness resulting from receiving health care. But there's a whole bunch of layers underneath that makes patient safety performance capable. And so it's important that these other layers are investigated when looking at patient safety. Pantankara also looks at safety culture and grades it on a spectrum from weak, which includes your secretive. If something happens, don't talk about it, put it under the carpet, and don't speak of it anymore, to the blame, shame, to bad doctors do bad things, good doctors that are trying hard, things don't happen in their offices, to reporting, understanding that If something happens in your office, there's a likelihood that it's going to happen someplace else, and if we report it, we can actually learn from it, and that moves into the trusting environment. That's the patient safety culture continuum. The patient safety movement really started in about 1999 in healthcare with the Institutes of Medicine's seminal report called To Err is Human. And with this report, their underlying message of it was that we do need to report and understand, and the focus needs to be on the system rather than the individual person that the incident may have occurred to. And with that is a model that James Reason has introduced, and a lot of people, they talk about this end being the sharp end, or the end where the harm actually happened, and a lot of focus has gone here, but the model of To Err is Human really suggested that we go back and look at the blunt end of it, and look at all these chunks of cheese models, places that something could have been in place, but wasn't working properly, that allowed the error to happen. And if we look at these, we might be able to reduce the errors from actually happening. So that's patient safety in a nutshell and quickly, but some complexities to study that, or to actually implementing or having a patient safety culture, is that lots of science has been done on what healthcare is delivered, but not necessarily on how it is delivered. So again, the systems in which we deliver healthcare. Another one is that healthcare actually plans for perfection, but we don't plan for error, and that healthcare providers are hardworking and smart people. But at the end of the day, both with the perfection and with the hardworking and smart, that humans are fallible. And I've heard the quote, but I don't have the paper behind it, but that the average person makes two mistakes every hour. And so you add on top of that healthcare providers' normal settings, which can be stressful and fast-paced, and those errors can increase immensely. Another complexity when it comes to the research or the science behind patient safety is the language in which you use. So in research or in epidemiology, systematic reviews or randomized controlled trials, that's where causation, the word causation, you can actually start to equate that. Down here on these clinical observations, you can't say a cause and effect, they're just clinical observations. However, in patient safety research, this is really flipped on its head. In clinical observations, you do root cause analysis, and you look for causal factors in a single observation. And so it's important when we go to study this that we're making sure that the language that we use is clear to everyone at the table of how you're using terminology to describe your cases. Another complexity that will bring me into the spinal manipulation therapy world is that most healthcare has been focused on hospital-based institutions, and rightfully so. The To Err is Human report came up with the huge number of medical errors that were happening in such conditions, but since that time, not a whole lot of not the change that they would have liked to have seen that has happened in patient safety. But patient safety has also not been focused in ambulatory settings or community-based providers, which is actually where most healthcare occurs. And so there is a recent evolution of moving into medical offices and nursing homes and pharmacies, but I think that's another complexity or important piece to this, is maybe if we can set the tone of patient safety in the places where most people are receiving care, that can actually triculate into our bigger, more intense environments such as our hospital systems. That brings me to spinal manipulation therapy and patient safety. I'm going to pause right here, and the study that I've done a lot of my work in is actually in Canada, so I think it's important that, one, we talk that spinal manipulation therapy can be provided by multiple providers. That includes medical doctors, doctor of osteopathy, doctor of chiropractic, naturopathic physicians, as well as physical therapists can all have training in spinal manipulation therapy. And those trainings, that training how that's regulated does vary from country to country as well as state to state here in America. But in general, I'm speaking of spinal manipulation therapy as a therapy in itself. So just to give a little background, because I'm assuming that everybody on here may be familiar with spinal manipulation therapy, this chart comes from the National Health Interview Survey from 2012, and chiropractic and osteopathic manipulation is on here. And as you can see from here, it is one of the 10 most common, what they consider complementary health approaches for adults. And from here, 8.4% of the U.S. population had manipulation done in that year. Another survey that was done was put on by the Pohlman College of Chiropractic as well as Gallup, and they had found that over half of the U.S. citizen had used chiropractic care, and chiropractic care is a profession that commonly uses spinal manipulation therapy, but that's not the sole thing that they can do. And again, it's not other providers can deliver spinal manipulation therapy. But just to get an idea of how often it's being used, over half of the U.S. citizens have said they've used chiropractic care, and 1/4 of them would use it again for back or neck pain. The next study came out earlier this year, and it just looked at one musculoskeletal conditions, acute low back pain, but it had stated that a systematic review looking at spinal manipulation therapy had found that spinal manipulation therapy was associated with benefits in pain and function, and they were able to gather adverse event information, and so that there were increased pain, muscle stiffness, headaches reported in about half of the cases in this study. Moving on to like the general risk, and that study was able to look at acute low back pain, but of course spinal manipulation therapy can be used in other areas of the spine, and so there is still a lot of uncertainty that exists in both the incidence of risk for spinal manipulation therapy as well as severity. Another complexity with that is that the natural history of musculoskeletal conditions is highly variable. And together, this makes it difficult for practitioners to communicate both with their patients, for them to understand the risks that they are taking when they have this therapy done, as well as with other healthcare providers. So at the end of the day, more clarity is needed on this topic, which leads me to the SafetyNET team, which was it has principal investigators from these 3 universities up in Canada, and it was funded from CIHR, which is NIH's reciprocal up in Canada, as well as Alberta Innovates Health Solutions and Women's and Children's Health Research Institution. My PhD is actually focused on chiropractic care, safety of chiropractic care in the pediatric population, and was funded by that. I don't get into that because I'm just wrapping up the data of that right now, but that is a piece of this study. Of course, it takes a village to raise a child and to conduct a research project, and this research team is full of experts in both spinal manipulation therapy as well as patient safety. It has diverse leaders from all professions involved in it, so I've been very fortunate to be part of this team. And the team is broken into 4 different projects that allowed us to look at patient safety from different aspects. And there was a quality team, a health law team, a basic science team, and then a community-based team. I'll spend the majority of my time here because this is, directly in the field. But I'm going to walk through a few projects that came from these studies briefly here. So the qualitative team, one of the projects that they did was to interview actually patients in a chiropractic office, and what they were looking for was the informed consent itself. The document can a lot of times be looked at as just as a legal aspect that somebody signs, but it is meant to be a document, not just a document, but actually a process. And so they interviewed individuals to see if what was taking place in the exchanging of risk information during informed consent was actually what the legal perspective wanted in an informed consent process. And they did find that that this is happening, and so it can happen that risk information can be properly portrayed during an informed consent process. Another study that the qualitative team did was to actually speak with frontline practitioners from all professions in Canada that was regulated for spinal manipulation therapy, which included chiropractic, physiotherapy, naturopaths, and medicine, and asked the leaders as well as frontline practitioners their thoughts on their readiness to implement a formal way to track adverse events. And essentially, they said that it would be very complicated and very difficult, but at the end of the day, they did feel that the collaborations across professions would be important as long as it was anonymous. Then Project 2, the health law team. The health law team did a lot of interesting stuff just looking at how social media influences perspectives of safety within spinal manipulation therapy. And then they also went into a complexity of spinal manipulation therapy, or any research in patient safety, is that the legal ramifications, and so practitioners could be scared to take part in the study and fear that a lawyer may come and grab that information and actually penalize them. And so when they looked into this, what they found is that it is true that it is not privileged information. A lawyer could actually do that, but that actually happened in very rare occurrences, and this information has allowed health policy makers to start to try to develop laws to protect such information so better studies can be done. And then the basic science team. So the basic science team looked at the reasons behind somebody with a condition going into a chiropractor, getting the chiropractor or physiotherapist and getting one technique done, and one person feeling great and the next person not so much, and why that happens. And so the first study that they looked at did find that there is real differences depending on the vertebral body as well as the application of spinal manipulation therapy. So it does vary. And then the second study, another study that they looked at, was looking at spinal manipulation therapy and how it differs from passive spinal movements. And again, it did have different attributes, but all of the attributes were below an injury values that had been described in the literature. And so moving on into the Project 3, the community-based. This is where I've spent the majority of my time doing research in this, and the two parts that I'll speak of today is a survey that we've developed as well as a reporting system. So the survey, we actually scoured the literature to find something that might work for the populations we were targeting, and we came across this medical office survey from the AHRQ. And so with a little bit of modifications, we found that this survey, while long, could be introduced to spinal manipulation therapy provider's office with ease. And so the survey has now been done in several different places, as well as in teaching institutions, as well as practitioners' offices. And so we are getting a diverse database of information. A key aspect of the survey is the patient safety dimensions. And so they look at these dimensions, measure them. One group that we did was chiropractors and physiotherapists in Canada. And so this table displays those results. On here, what we have is strongly agree is the light bar, and that we want that number to be high. The big black bar is actually the 2016 AHRQ medical office database, so it's something to be comparative to. And so you can see here that the SMT providers' offices did seem to have a robust patient safety. What we are hoping to do with this survey as we get a database together is, one, it's great that we can compare ourselves to medical offices, but spinal manipulation therapy providers' offices do have unique attributes to them, and so we're hoping that we can have our own database so that one can compare themselves to offices more similar to their own. Another beautiful thing about AHRQ's database is that if you're low in an area, such as staff training, they have a whole list of evidence-based systems that have been put into place to actually increase this in your office. And so we're hoping to do the same, be able to provide, if you're low in this area, what can you do to fix that. So future studies in this area. And the other piece I'd like to talk about is the reporting system. So the reporting system, our goal with this is many layers. One is just to get a better understanding. Like I said, there's a lot of uncertainty with just the incidence and the severity of adverse events that may happen after spinal manipulation therapy. And so the study is looking to prospectively evaluate if we can get a handle on the incidence and severity. And then from that, piggybacking off what the basic science team has done, and is there ways that if we can identify risk factors or prognostic factors, and then to go even further with that, are there ways to mitigate that? And so really the patient safety aspect of it is for patients to have a better understanding if there's risk factors so that they can be more clear about the risk and benefits that could occur. And then is there ways that the professions delivering spinal manipulation therapy could perfect that delivery? And so the way that we've designed this study initially is with paper forms so that everything is anonymous and confidential. And a patient we're collecting data from 100 consecutive patients at different offices. Patients fill out this information, which is their basic health information, before they see the doc. This little form asks them, I know you can't read this, so I'm not expecting that, it is a list of symptoms that they may feel afterwards. And then the provider fills out a form following treatment that tells them what kind of treatment was given, and then any post-symptoms and how the patient feels immediately after care. The patient is then sent home with another form and a stamped envelope that they can describe how they feel. We ask that it be 2 to 7 days after treatment. They send it directly to the investigators. Again, we do collect satisfaction data, an NRS scale, and then how they feel on specific symptoms. Preliminary results. Here's a list of symptoms that actually come from the literature that do commonly or have commonly occurred after spinal manipulation therapy, and how they're looking. So improved, no change, and then worsened. And worsened is actually what we would call the adverse events. And this is broken down into percentages. And so this is the reason why we need a large database, is that this is, they appear to be a rare occurrence, and so we do need a large database so that we can look into risk factors and prognostic factors. So from people that have completed the study, providers found the forms that we made it check boxy, so it's easy to complete. It's not interfering with practices. Patients are interested in it, happy that their providers are participating. One of the things that when we were designing this study was a fear was that if we had a whole list of symptoms that a patient may feel, would that be some sort of hypervigilant? And we're not finding that being the case, and it's actually I've heard lots of feedback around the patient and provider actually having a conversation that they never had before, and that being a good opportunity. And I've recently came to Parker University. It's been about 2 years now, but I've been able to implement this in the student population. And so just to get a comparative database, where there's difference between students learning as well compared to practicing providers, and we are getting similar outputs. one of the unique opportunities with working with the student population is that a lot of times they don't focus on how to have a conversation when somebody actually doesn't feel better, and so we've been able to have lots of discussions around that. And so SafetyNET will continue to be implemented here at Parker University. And so just to rehash is that patient safety, again, is the avoidance of injury or illness resulting from receiving health care, which is the very tip of this patient safety pyramid. I think SafetyNET lines of investigations have done a good job of trying to explore these many different layers so that this performance can be at its peak, especially when the SafetyNET, when it comes to regard to therapy of spinal manipulation. This is my final quote, and I went much faster than I hoped. And so I can open it up to questions at this point. I'll see if Sarah's still there.
Hi, Katie. Yes, I am. So we'll wait and see if people have questions. They can use the chat box to go ahead and ask their questions. I actually have an initial question for you, Katie. Can you talk a little bit more about where you're hoping to go with this research in the future? Maybe what are some future topics you're interested in looking at?
Yeah, thanks, Sarah. So one is the mitigation piece of that. Is there things that can be done before or after a spinal manipulation therapy that can reduce the number of even the transient events? And then the study was done or is being done in a general population, but I'd like to go into more specific populations to get a better understanding. For me specifically, pregnancy in the postpartum population, as well as geriatrics. As we all know, with the increase of the opioid epidemics, we need to find a non-pharmacological solution or help for people with pain, and if we can start to investigate making sure that other options are safe and delivering them in the safest aspect, I think, is important.
Thanks, Katie. Looks like we have a question from us in the chat box about the slides. Yes, we do have a link to the slides. Debbie can put a link back in that chat box. Again, there they are. Another question, Katie, that came into our private chat was to find out a little bit more about the what specific adverse effects are possible in spinal manipulation therapy. What is there to look for, and what should we be on the lookout for in that?
And so the list that I had here, these are common ones that people feel from the literature. Our list here, I'm going to go back one more slide. No, sorry guys. Right here, this reference right here, 2010, so not the most current. I do know of other systematic reviews coming out, but this is the adverse event systematic review that I referenced right now to the current incidence and severity. But the list of common things that do occur would be back here. And it's just understanding the incidence as well as the severity of these things. And again, this list is people with musculoskeletal conditions not getting any therapy. This list is very similar to that. And so that's what makes it difficult to discern.
Thank you, Katie. All right, I think we'll give it a couple more minutes here. If people are typing in the chat box, please continue to do so and go ahead and enter those. We'll wait and see if we have other questions come up. All right. Well, Katie, if you would go to your last slide one more time.
Oh, yep. Thank you.
Just so that if people do think of questions later on, think perhaps after reviewing the slides or reviewing the recording, do you mind if they email you, Katie?
Absolutely. So, or absolutely not. Please email me. There's my email address as well as the SafetyNET project's email address, and we do have a Facebook page that where studies come out and its findings. We put it there.
All right, great. So if you do think of questions in the future, you can go ahead and email Katie. If you forget either of these things, of course, you can email us as well. And if you have any questions, you can go ahead and stick them in the chat box. But now we'll go ahead and stop the recording. But first, thank you again so much for kicking off this webinar series, Katie. We really appreciate you being our first speaker for the series.
Thank you.
All right, so I'll go ahead and take the ball back now from Katie, and I will get the recording stopped. And then we do ask that everyone stick around for a few more minutes. We have a few final housekeeping items to cover.